Let's get one thing very clear before we start. Mammograms remain the best breast cancer screening tool at this time and are pretty much indispensable, reducing breast cancer deaths in women by an estimated 15 to 25%. But even mammograms have their limits. As you can see on the table, the National Breast Cancer Screening Program saves an estimated 1,300 lives each year in the UK, which is by all means impressive. But this number still falls significantly short of other screening programs. Screening for cervical cancer, for example, saves the lives of an estimated 4,500 women each year in the UK. This has made breast cancer screening a particularly controversial issue, with the debate mainly focusing on when women should receive their first mammogram and how frequently these mammograms should be. In the United Kingdom, for example, women begin screening at age 50 and are invited for a mammogram once every 3 years. And the guidelines are pretty similar in Canada. In the European Union, however, the recommendation is to begin screening at age 45, and the United States of America is a complete and utter mess, with the American College of Radiology recommending women as young as 40 be screened annually for breast cancer. The American Cancer Society has different ideas, however, and recommends 45 as a good starting age, but the International Agency for Research on Cancer warns against this, and the American College of Physicians states that the potential harms of screening outweigh the benefits in most women aged 40 to 49. Wait a minute. Potential harms? What harms? It should be remembered that younger women have breast tissue that is typically more dense than older postmenopausal women. This creates a bit of a problem for mammograms as it reduces the device's ability to see into the breast tissue, identifying breast cancers, which substantially reduces the sensitivity of the screening test, leading to more cases of overdiagnosis and an increased chance of being flagged as a false positive, or even being missed as a false negative. Add this to the fact that women between the ages of 40 and 49 are significantly less likely to develop breast cancer anyway, so they stand to gain less from a regular breast screening program, all while still having to put up with the potential risks that come with screening. So, are 40-year-old women really too young to receive mammograms? Let's find out. My name is Hesham and I'm a University of Cambridge graduate and student doctor, and this is my YouTube channel where I get to read all the latest research and share all the cool stuff that I learn with you guys. There is a substantial amount of research indicating that women remain largely unaware of the exact benefits and risks that come with having regular mammograms. This video aims to use the research to address this, because patients who are better educated are also patients who can make better informed decisions about their personal health. And if you'd like to support the channel, then the best way to do this would be to give this video a thumbs up and to subscribe to the channel for more awesome research-backed videos just like this one, delivered right to your doorstep, or YouTube homepage in this case. Breast cancer is the most common form of cancer affecting women. In the United States, this translates to roughly 1 in 8 women developing invasive breast cancer within their lifetime, and an estimated 2.3 million new cases were diagnosed globally in 2020. The good news, however, is that deaths caused by breast cancer have been steadily declining since 1990. Across all age groups. This means that we have more breast cancer survivors alive today than we've ever had before. In other words, breast cancer is more treatable than it has ever been. However, while screening programs are responsible for some of this improvement in survival, through picking up on cancers early enough before they present clinically with symptoms and allowing for their swift and decisive treatment, this also happens to be mammograms' biggest drawback because it leads to overdiagnosis. Overdiagnosis refers to the detection of cancers on a mammogram, which would not have become clinically relevant during the woman's lifetime. These are typically non-invasive cancers with such a slow progression that they would have never ever been found nor treated had the patient not gotten a mammogram. The problem is that it's basically impossible to tell which cancers will not progress and which cancers will grow and spread. Ductal carcinomas in situ, or DCIS, contribute significantly to this phenomena of overdiagnosis. Ductal carcinomas are malignant cells arising from the epithelial cells of the milk ducts. However, most of the time they will not spread beyond the milk ducts in which they first appeared. They are therefore most commonly detected through mammograms as microcalcifications. Some ductal carcinomas, however, are able to acquire the capacity to continue to grow and even invade surrounding tissues, which makes the decision on which patients to treat a particularly difficult one. And so most patients with these slow-growing tumors will end up receiving a lumpectomy or even a mastectomy as treatment. What's clear though is that ductal carcinomas are fairly common. They account for around 20% of all breast cancers diagnosed by mammography, and were found in 9% of women in a post-mortem autopsy series of females without known breast disease. Basically, nearly 1 in 10 women who died of old age had these slow-growing tumors in their breast tissue, and they were just fine. Now, scientists have struggled trying to estimate the number of women who are overdiagnosed by screening programs each year. Most estimates from the UK, however, suggest that there are between 2,500 and 4,000 overdiagnosed cases a year. Now, remember that the breast cancer screening program saves an estimated 1,300 women each year. This effectively means that a woman is 2 to 3 times more likely to be overdiagnosed by a mammogram than to have her life saved by it. Which brings us to this next issue of false positives. Unlike overdiagnosis, where cancerous cells are actually present in the breast, false positives happen when a mammogram picks up on an abnormality in the breast tissue despite the breasts being completely normal. This tends to be an issue in women who are getting their first mammogram, and also in younger women who have more dense breast tissue. And false positives are significant because they will at some point affect 1/2 of all women who undergo annual screening within a 10-year period. Despite the fact that most of these false positives will not require treatment, they will almost certainly require further investigations. Things like an MRI, an ultrasound, or even a breast biopsy, which can cause a tremendous amount of anxiety. So much so that several studies were able to show that psychological distress from a single false positive result can last for up to 3 years, and a female patient who had received a false positive was 37% less likely to attend future screening. Now, this is an issue because despite all the flaws that I've just mentioned, mammograms really do save lives, and there are women out there who probably would benefit from receiving annual screening. At the beginning of this video, I told you about how breast cancer screening programs reduce the risk of death from breast cancer by an estimated 15 to 25%. But this means nothing for most women because 7 out of 8 women will never develop breast cancer in the first place. However, it does make a huge difference in the lives of those women who do end up developing breast cancer. A different way of looking at the numbers is looking at them this way. For every 100,000 women screened, roughly 800 cancers will be detected early and 9,500 years of life will be saved. This works out to be an average of around 12 years for each of those women screened, diagnosed, and receiving early treatment for breast cancer. And no matter what way you look at it, 12 years is a lot of time to spend with a loved one. If my grandmother had gotten these extra 12 years, she would still be alive and with us today. She would probably still be watching all my videos with you guys. But unfortunately, she's not. And I just have to make do with all of you instead. Now let's summarize all the research. The debate about breast cancer screening seems to be misguided. The question should never have been when to start screening women and how frequently to screen them. Instead, we should look at each woman's personal risk of developing breast cancer and calculate that personal risk, and then use the research to come up with an individualized screening program for that woman, where the women who are most at risk get mammograms earlier and more frequently. That way we can maximize the benefits that mammograms have to offer while also minimizing risks. I'm kinda shocked that I need to say this, but everyone is different, and everyone has different risks for different diseases, and a one-size-fits-all model never works because it ends up fitting absolutely no one. Don't forget to give this video a thumbs up, subscribe and hit the bell icon, and share this video with friends and family. And now, I'll see you all next week.